So good evening once again. Welcome to this weekend's tutorial. We'll continue from where we stopped last week. We started cardiac arrhythmias, and I will just do a little summary, and we'll deal with what we have today. All right, so we started with these scenarios, and we discussed that last week. And we also talked about the physiology of the electrical activity of the heart. The SA node being the pacemaker of the heart, located at the junction of the inferior vena cava and superior vena cava in the right atrium. And we have the AV node, the bundle of His, the Purkinje fibers. So this is a picture of the electrical activity of the heart. And we talked about the action potential of cardiac muscle. The resting membrane potential in cardiac muscle ranges between minus 50 millivolt to 96 millivolt. At the influx of sodium ions into the salt, the polarization takes place, and this takes the resting membrane potential to minus 70. All right, and we have the plateau phase. All right, at this stage, no electrical activity can trigger any stimulation of the cardiac muscles. Then we have the repolarization phase, which occurs with the opening of the voltage-gated potassium ions. And this returns the resting membrane potential back to minus 90. Then we have the refractory phase. All right, so this is sometimes you may be asked to label this in an exam, so it's good for you to just have an understanding of this diagram, all right? Then, so we talked about arrhythmias, and we did say these are abnormal rhythms of the heart, and they can be divided into different types based on the origin of the arrhythmias, either supraventricular, that is occurring above the ventricles, and ventricular, that is starting from the ventricles. Arrhythmias can also be classified based on the rate, whether it's low, which is bradyarrhythmia, or high, less than 60, low, and above 100, high tachyarrhythmias. We also can categorize them based on regularity, looking at the RR waves, whether it's regular or irregular. And some arrhythmias, like the AF, can be irregularly irregular. All right, we also talked about disorders of impulse formation and impulse conduction. And another very important one is to distinguish it based on the width of the QRS complex. All right, so we have narrow complex arrhythmias, all right, with less than 0.1 seconds, while the broad complex is about more than 0.12 seconds. And these are different ways. We looked at the atrial fibrillation, which is the most common sustained arrhythmias. And we said that it increases with age and is common among the male gender. We looked at supraventricular tachycardia and all of that. And we did say that ventricular arrhythmias, which could either be VTAG or VF, are less common, but they are dangerous, all right? So we talked about the different mechanisms and all that. So approach to diagnosis is that you want to, first of all, look at the arrhythmia. Is it a narrow complex or a broad complex or a wide complex? All right, looking at the RR intervals, you look at the regularity. Okay, so we looked at basically atrial arrhythmias last week, and we looked at how to differentiate between atrial flutter and atrial fibrillation and their treatments. Okay, and we talked about supraventricular. Okay, we talked about atrial fibrillation and how to estimate the risk of a patient with AF coming down with stroke. And we looked at the Chadvius score, all right? And we said any score which is 0 shows that there's no need of anticoagulation or aspirin because the risk of stroke is low. All right, a patient with a score, CHAD score 1 and above, will require some form of anticoagulation. Definitely, if it's more than 2 and above, you want to give this patient anticoagulation. The important thing is you want to prevent stroke. All right, the problems with atrial arrhythmia, atrial fibrillation is impaired cardiac feeling, and all right, and it's increasing the incidences of stroke developing. All right, so if you are presented with these ECG tracings, you should be able to differentiate between atrial flutter, all right, rapid rates, but they are uniform, all right? Why the atrial fibrillation, you have the fibrillatory waves, all right, they are irregular, but also very fast. All right, we talked about all this. So today, let's just, that's a little background of what we did last week. So today, let's look at this scenario. All right, so a 58-year-old male patient with a history of hypertension and type 2 diabetes presents to the emergency department with chest pain, which radiates to his left arm, with associated shortness of breathing and diaphoresis. His initial ECG shows SC segment elevation in the anterior leads, and as he was being prepared for emergency percutaneous coronary intervention, it suddenly becomes unresponsive with no palpable pulse. All right, so the cardiac monitor shows a chaotic, disorganized rhythm without identifiable KRS complexes. So let's take a go at it. All right, patient with suspected MI from the ECG ST elevation being prepared for PCI suddenly becomes unresponsive. And we've just described the ECG tracing. So what is your most likely diagnosis? And what are your immediate steps in managing this patient? Anybody? Quickly, anybody? Aliyu. Aliyu, Afonsinia, Ada. Quickly, let's quickly talk about this so that we can discuss. What's your most likely diagnosis for this patient and how will you go about it? Don't write in the chat, just unmute yourself and let's just discuss. Dr. Ikapot, go ahead.
Okay, I'm thinking this patient has pulseless electrical activity.
Sorry?
So, pulseless electrical activity.
What? I didn't hear the electrical activity.
Pulseless electrical activity.
Pulseless electrical activity.
Yes.
Okay. So from the description of the ECG, what do you think?
Okay, ECG shows ST segment elevation in the anterior leads. That points towards the anterior myocardial infarction.
Yes.
As he is being prepared for emergency pecunias, he suddenly becomes unresponsive. So I was saying the pulseless electrical activity because the ECG shows the chaotic rhythm. However, the patient doesn't have a palpable pulse. However, from the introductory part of the case, it suggests that the patient has an acute MI.
Yes, we know that this patient has an MI, and that's why emergency percutaneous coronary intervention was being prepared. But before he could get that done, he became unresponsive with no palpable pulse. And at this point, the ECG does not only show ST elevation, shows chaotic disorganized rhythm. So with these new ECG findings, what do you think this patient has? And what points to that? Zeno wrote something, please. Can you say Zeno Gloria? Unmute your mic, please. I want to hear you.
Okay. I think the patient has ventricular fibrillation.
Yes, this is VF, ventricular fibrillation. All right. What points to it from the history and from the ECG tracing?
From the history, patient is unresponsive, has no palpable pulse, and then the disorganized rhythm without identifiable KRS complexes.
Beautiful, beautiful. So this patient is in VF right now, okay? And we remember that the causes of shockable rhythms, cardiac arrest is VF and VTAC, okay? So how will you go about managing this patient? What will be your immediate steps and how will you manage this patient? Zeno, you are still on the hot seat.
Okay, start immediate cardiopulmonary resuscitation.
So you want to start CPR, correct? You want to start CPR, all right? Then go ahead.
Yes. And electrical cardioversion.
Yeah, is it electrical cardioversion? Do you want to, is it cardioversion you want to do or you want to defibrillate?
Sorry, defibrillation.
Okay, Zeno, this is how exam goes, huh? So, anybody, what's the difference between cardioversion and defibrillation? Zeno, you can call your friend, you can call a friend. So what are the differences between cardioversion and defibrillation?
Dr. Aliyu.
Dr. Aliyu, you have been nominated. Why, Dr. Oh yeah,
Yes,
Dr. Aliyu, go ahead.
sir, for the cardioversion, we synchronize the energy that we give with the QRS complex in order to change the rhythm of the heart to normal. While for defibrillation, we don't synchronize and we use higher energy during defibrillation, while we use lower energy during cardioversion.
Those are two beautiful, those are two differences. Olukayode Opadola, you want to help? Well done, Dr. Ali. Well done, Dr. Zino. Olukayode Opadola.
Yeah, thank you, sir. I think those are the ready points I could remember now, which has been said. And apart from that, I was thinking that since it was a ventricular fibrillation, it's advocated early defibrillation rather than as long as you have a defibrillator with you. I think I was thinking that should be the first thing to defibrillate and get the rhythm back rather than commencing chest compression or giving medications.
Yeah, you know, this patient is pulseless, all right? Immediate defibrillation, then CPR, I agree with you. And there are some of the differences between cardioversion. We'll see them as we go on. Cardioversion is usually elective, while defibrillation is emergency. So this is emergency, So it's defibrillation you will do here, not cardioversion. And the cardioversion, most of our patients are awake, all right? And that's why we need some degree of sedation. Why defibrillation, they are already in cardiac arrest, so to say. So good point here. Any other comments before we go on, Ada? Anfosina?
Yes, Prof.
You can say you agree or you have no other addition.
Okay, I agree, Prof. The patient has pulse. Yes, it's in ventricular tachycardia with pulse, but for defibrillation, it's pulseless ventricular or ventricular fibrillation.
Okay. All right. Anfosina?
I also agree with defibrillation.
Okay. So let's just go there. Beautiful contribution. Okay, so let's look at ventricular arrhythmias. Like we did before, we talked about atrial arrhythmias. Let's talk about ventricular arrhythmias. So they can be classified into, various. The commonest ones are the life-threatening ventricular tachyarrhythmias, the VTACs, and the ventricular fibrillation that we mentioned before. We can have Torsades de Pontis, we can have ventricular premature beats or ventricular premature contractions, your VPC, and we can have normal heart rate ventricular tachycardia, normal heart ventricular tachycardia, and non-sustained ventricular tachycardia. But the four of them is what we're going to be looking at. We'll look at the VTACs, VF, to simulate the pontis and your ventricular premature contractions. Okay, so VTACs, all right, this is a condition in which the signal from the heart is sent from the ventricles at a very fast but very regular rate, all right? So on your ECG, you should see a rapid ventricular rhythm, all right? It's a broad spectrum most of the times. The QRS width is more than 0.12, all right? And it's characterized, the difference between VTAC and atrial SVT, supraventricular tachycardia, is that in ventricular tachycardia, there's AV dissociation. So there's no relationship between atrial and ventricular contractions or activities. So there's AV dissociation. And most of the times in ventricular tachycardia, the patient most likely have a primary heart disorders or heart disease. All right, just like what we said before, this patient we looked at, although had VF, it had MI, all right, it was being prepared for PCI before the patient crashed. So in VTACs, the patient had AV dissociation, and if you look at the history, they have either ischemic heart disease or coronary artery disease, or whatever it is, the primary heart disease they have. All right, so treatment of VTACs depends on how stable these patients are in terms of hemodynamics. All right, if the patient is hemodynamically unstable, remember this is cardioversion because this patient has a pulse, all right, and is ventricular tachycardia. But if the patient is hemodynamically unstable, if the patient is stable, you want to use pharmacological methods, all right, your amiodarone, lidocaine. But if your pharmacological treatment fails, you may want to cardiovert this patient. So one other difference is that a lot of times you can actually use cardioversion for VTAC, but not for VF, all right? So cardioversion may be necessary if the pharmacological therapy is unsuccessful. Don't forget amiodarone has dual roles, like I mentioned before. It helps to control the rate and tries to stabilize the rhythm once a normal rhythm has been restored. For patients who do not tolerate amiodarone, you can use lidocaine, all right? Lidocaine is class 1, okay? Antiarrhythmic, so 50 to 100 milligram IV over 5 minutes, and you can follow with infusion, but note that this requires careful monitoring. Okay, so like I mentioned before, sometimes you may want to differentiate between ventricular tachycardia and supraventricular tachycardia, and these are some of the differences that we can look at. Okay, don't forget that for SVTs, they originate above the ventricle, so they have a narrow complex, while VTAC originate from the ventricles, they have a broad complex. Okay. Now VF, this is the problem, all right? So the electric signals are also sent from the ventricle, so it's a ventricular arrhythmia, broad complex, and it comes very fast and very erratic. So what happens is that there's hemodynamic instability most of the time because the ventricles are unable to fill with blood and pump, so there's reduced cardiac output. This is a life-threatening rhythm, all right? Because there's no pulse and there's complete loss of consciousness. The ECG shows shapeless rapid oscillation and there's no organized complex. Look at what we look at the clinical scenario we talked about. So you convince yourself, are we all convinced that this patient had developed a VF while in the emergency room, all right? So just to link what we said before with the lectures we are given. So this patient became more responsive with no palpable pulse, and the ECG shows chaotic, disorganized rhythm. You can't get the normal complex on your ECG. So what do? Requires prompt defibrillation, all right? Prompt defibrillation, like I mentioned, defibrillation is emergency. So this patient requires defibrillation. If you have automated defibrillator, or you have the conventional defibrillator, all well and good, but this patient requires defibrillation, and in between giving your shocks, you need to perform CPR, basic and advanced cardiac life support. All right, you want to quickly intubate this patient and give advanced cardiac life support after you initiate CPR. All right, now if the patient survives, before you go to take the patient for percutaneous coronary intervention, you want to put a cardioverter inside this patient. All right, so it prevents further VF for developing. So this is the management for this patient, and this patient will require to be admitted to the ICU or cardiac unit or coronary unit for further management. All right, so this is an ECG of a VTAC and a VF. All right, you can see that the VTAC rapid rates, but the QRS complex is organized, okay? While in VF, disorganized, all right? You can see it's erratic. There's no, continuity. You can actually make out the QRS complex from the ECG of VF. So the second one we're looking at is the premature ventricular contractions. All right, although they are uncommon, sometimes they may become symptomatic and you want to treat with beta blockers. So it's good for us to remind ourselves what these rhythms really are. So premature ventricular contractions. Indeed, the electrical activity originates from the ventricles and causes the ventricles to contract before receiving electrical signal from the atria. Remember, we said that SA node, then AV node, then you have your bond of His. So before the ventricles receive electrical stimulations from the atria, all right, there's a premature stimulation, the electrical activity that originates from the ventricles. All right, so the ECG will show wide bizarre KRS complex because the ventricles are responding to their intrinsic electrical stimulation. They are still trying to respond to the stimulation from the atria. All right, so you see early R on T. The R wave is badging on the T wave, and this shows you ventricular premature beats. All right, and the important of noting this early is that it can actually induce your life-threatening ventricular fibrillation. So it's important when you see R wave aborting on a T wave, it signifies a ventricular premature contractions. All right, and it's important for us to quickly, cardiovert at this point before it goes into ventricular fibrillation, which is life-threatening. All right, so tosalis de pontis is a short duration tachycardia, QRS tachycardia that usually reverses to sinus rhythm spontaneously. All right, so it could be due to congenital abnormality, electrolyte disorders, and it may be secondary to drugs like your TCAs, and actually it can also be secondary to your antiarrhythmics, especially your class 1 and your class 3 antiarrhythmics. Tosalis de pontis, usually the complexes are irregular and very, very rapid. And how do you know? They twist around the baseline, all right? So there's a twisting. This is a normal KRS complex, all right? The QT interval is long, but as it goes to the baseline, there's a twisting. It's a French word, tosalis, all right? Twisting around the point. Tosalis de pontis. So there's twisting around the baseline, all right? Twisting instead of the regular waveform. So it can result in syncopal attacks, and the problem is that it can actually predispose to ventricular fibrillation. Okay, the ECG will show prolonged QT interval. How do you manage? You want to find out what is causing this, or what's the precipitating factor. All right, is it electrolyte disturbances like hypokalemia, hypomagnesemia, and hypocalcemia? And for all your care, tosalis de pontis may be commoner than we are aware of, especially in the ICU, when we have patients with refractory hypokalemia and hypomagnesemia. So please be on the lookout for it. And if you see, let's collaborate. If you see any of these ECG changes in your unit, please take a picture and send it on the WhatsApp group. All right, so we'll begin to collect our own database. Okay, if you say to send it upon this, please take a picture. All right, a VF, anything, take a picture for learning purposes, send it on the group. Now, you want to correct any causative drugs. All right, sometimes it may just be due to cardiac pacings or pacers in the patient. So you want to give magnesium sulfate, all right, about 8 millimole over 10 to 15 minutes, all right, for those who have acquired long QT interval. Isoprenaline in acquired cases and beta blockers are indicated when it's due to congenital abnormality. So the next arrhythmias we're looking at is those ones based on rate, abnormal rate. So we're going to talk about, let me remove this stuff. Okay. Sorry. Sinus bradycardia. All right, I'm sure many of us come across this either in the OR or in the ICU. Sinus bradycardia, when this is usually due to a strong vagal tone, all right, when you have a strong parasympathetic reflexes, or it may actually be due to athletic training. Remember that some of these causes are very common, especially in the OR, during Valsalva maneuver, rectal surgery, hemorrhoidectomy, and all that. Be on the lookout for it. Patients, when you're having surgery around the neck, aortic sinus stimulation. So these are very important bradyarrhythmias, and you want to find out, all right? Especially the heart rate at rest, all right, if it's below 50. And sometimes the heart rate can go as low as 40 during sleep. So the causes could either be intrinsic or extrinsic. Most of the intrinsic causes are due to heart problems like acute ischemia or infarction of the sinus node. So the rate at which the pacemaker says is, starting electrical stimulation is very low. It will actually be to 6 sinus syndrome, as we're going to see the next slide. We have extrinsic causes, I call it 4HD, hypothermia, hypothyroidism, hepatic jaundice, intracranial hypertension, all right? And this is common, especially in the first 48 hours after your traumatic brain injury, or even patients who have neurosurgical procedures, all right? So these patients can have the, bradycardia with hypertension, all right? And this is our normal, things we see with ICP. Drugs, patients on beta blockers, digoxins, and other antiarrhythmic drugs may have bradyarrhythmias, all right? And this is an ECG change. You see the PR interval is very, excuse me, is very long, okay? Now, 6 sinus syndrome occurs, all right, when the sinus node, the SA node, sends out electrical signals too slow or too fast, all right? Before symptomatic, the rate becomes too slow and too fast for the body to tolerate. Chronic symptomatic 6 sinus syndrome requires permanent pacing, all right? The patient required pacemakers, all right? And we have to get additional antiarrhythmic drugs or ablation therapy. Thromboembolism is common, all right? When you have tachybrady syndrome, the heart rate is high at the moment, the next moment the heart rate is very low. So this patient requires anticoagulation unless if there's any contraindication. So 6 sinus syndrome, this thing starts from the pacemaker cells of the heart. The other bradyarrhythmias that we have are the AV blocks, what we know as the heart blocks. We have different degrees. The first degree AV block or the first degree heart block, they usually cause no problem and unlikely to progress. But what you see on the ECG is that you see prolonged PR intervals, all right? And this may be associated with acute rheumatic fever, diphtheria, or myocardial infarction patients on digoxin. So the PR interval gradually increases. So most of the time, fourth degree heart block requires no treatment. Then if the second degree heart block can be divided into two, the Mobis type 1 and the Mobis type 2. In second degree heart block Mobis type 1, the PR interval gradually increases until you have a missed P wave, all right? Then when there's a missed P wave, it gradually continues to increase. When it's associated without any other problems, usually physiological, and like we said, maybe due to increased vagal tone, and this Mobis type 1 can actually be abolished by exercise, all right? And the heart rate increases, or atropine in most of the cases, your anticholinergics. In Mobis type 2, you realize that the PRL continues to increase, and sometimes you don't even see a P wave at all, not being conducted. And it happens when you have a drop PRS and the PRF is not preceded by a PR interval with PR interval prolongation. Usually in Mobis type 2, all right, pace usually indicated, all right, while patients in the Mobis type 1, the waking back does not usually require pacing and require just monitoring. Yeah, the third degree heart block, this is common in elderly patients, all right, most of the time is due to idiopathic bundle branch block or fibrosis, all right. ECG shows bradycardia with P wave continue and is unrelated to your QRS complex. Patients with third degree heart block requires permanent pacing. Let me look at the time. We must finish this today. Okay. All right. AV blocks can actually also be bundle branch block. Let me show you this from what we started with on the. Let me see. I hope it's not too far down. Okay. All right. So you can see the bundle of His, all right, is divided into right bundle branch and left bundle branch. So when there is abnormality with conduction of electrical impulses from the bundle of His, all right, so we can have a right bundle branch block or a left bundle branch block. All right, we'll come back to this again as we go to hemi block. Well, let's do that. Okay, so the bundle branch block will either be right or left, okay? When there's an interruption of the right or left branch of the bundle of His, there's delay activation of corresponding ventricles, all right? This will lead to broadening of the QRS complex. So most of the time, unlike the right bundle branch block, all left bundle branch block is usually associated with an underlying heart disease, all right? But both right and left bundle branch blocks show wide deformed PRS complexes, and you can notice this on your ECG. For the right bundle branch block, you see the RSR pattern in lead 1, V1, while in left bundle branch block, there's always a broad monophasic or a very tall notched arrow wave in lead 5 and 6. Hemi blocks, all right, like the left bundle branch also develops or divides into anterior and posterior divisions, okay? And when you have a delay or block in the division of the left bundle branch block, it produces a swing, all right, in the direction of the polarization of the heart along the electrical axis. If it is the anterior branch division of the left bundle branch that is blocked, you have the left anterior hemi block, all right? And your ECG, you'll see a left axis deviation. One of these days, as we continue, I will give you a lecture on ECG and how to interpret ECG, my common easy ways of interpreting ECG, all right? You'll see how to calculate your left axis division, and the delay or block in the posterior inferior division will cause a right axis deviation. And all these things can actually be recognized on ECG. But when there is a right bundle branch and or with the left anterior superior division or left posterior inferior division, we have what we call the bivesicular block. In all of them, the right bundle branch block is involved. Then you have either the anterior or the posterior division of the left bundle branch, that then you have what we call bivesicular block. All right. The block of this one will lead to a complete AV block, your third degree heart block. I usually require permanent pacing for this patient. Okay, so let's look at the diagnostic tools of arrhythmias. How do you make a diagnosis? The primary tool, all right, apart from clinical presentation, is the use of ECG, your electrocardiogram. All right, so and that is why it's important for you to be able to appreciate your ECG changes on your monitor. Most of the times, it depends on centers. We have a 3-lead ECG in theater. Some monitors come with 5-lead. All right, most ICUs will have 5-lead ECG. But when we're able to detect or we're suspecting, an arrhythmia, it's better for you to order and obtain a 12-lead ECG, because this will help you to identify the type of ECG, the duration, and severity. So most of the times, the monitor will give you maximum 5-lead, or if you suspect an arrhythmia, please do order for ECG. All right, for our patients who are ambulatory, you can do your heart lab monitoring. All right, and cardiac imaging test is also very important, because once you're able to pick an arrhythmia, you want to find out the underlying cause. All right, a cardiac imaging test will help you to evaluate the structure and function of the heart, and also to detect any underlying structural abnormalities. These are basic diagnostic tools that can be used. So how do you manage arrhythmias? You can use your antiarrhythmic drugs, all right? And we're going to look at that as we continue. Rate control agents, anticoagulation, anticoagulants, and adenosine, which is a miscellaneous antiarrhythmics. All right, so these are antiarrhythmic drugs, like mnemonics. So for you to remember the classification, class 1 to class 4, just remember some Black people care. All right, some Black people care. Some, class 1 is sodium channel blockers. All right, then we have different, reclassification class 1, but generally all class 1 antiarrhythmic agents are sodium channel blockers. Then Black, class 2, these are beta blockers, your metoprolol, your propranolol, and all that. Those are class 2 class 2 antiarrhythmic drugs. Potassium channel blockers, look, your amiodarone, all right, belong to class 3. And class 4 are your calcium channel blockers, or diatism. These are class 4 channel blockers, okay? Now we have all of these as the examples on the right side. Adenosine and digoxin, they are antiarrhythmics, but they fall into the miscellaneous groups. Okay, so these are subdivisions of class 1, okay? Class 1A, remember that I said all class 1 agents are sodium channel blockers. All right, so we have class 1A, class 1B, class 1C. Okay, lidocaine is a class 2. Class 1B, while procainamide, quinidine. Quinidine is rarely used anymore, all right, because of so many adverse effects associated with it. We have class 2, the beta blockers, propranolol, esmolol, metoprolol, and we have the potassium channel blockers, the class 3, amiodarone. Like I mentioned, miscellaneous adenosine receptor agonist, adenosine, and digoxin helps to increase vagal tone, and they all belong to the miscellaneous group. Okay, so there are different ways of managing arrhythmias. Like I mentioned, the pharmacological. Then we have the non-pharmacological, the carotid sinus massage. You know what this does is try to slow down the rate of the heart, all right, by increasing parasympathetic tone. Cardioversion, all right, implantation of a pacemaker or a defibrillator device, the implantable defibrillators. Whereas the catheter-mediated ablation, especially when you have an ectopic focus, all right, especially those ones connecting the atria to the ventricles, you can do ablation, catheter-mediated ablation, and catheterize that ectopic focus. Lifestyle modification is important, all right, especially in patients with chronic arrhythmias. Okay, so I mentioned cardioversion and defibrillation. All right, these are some of the common questions I like to ask on this topic, because you need to know when to cardiovert and when to defibrillate. And the processes of doing it also differs. Okay, so cardioversion is a planned elective procedure, while defibrillation is an emergency life-saving procedure. Like Dr. Ali mentioned, in cardioversion, you synchronize your shock to the R waves, or you synchronize it with the QRS complex. The reason why you need to synchronize so that you don't want to stimulate the heart in refractory phase. You're causing more damage to the myocardium. Why in defibrillation, you don't have the time, you don't need to synchronize your shock. Cardioversion requires low energy, like he mentioned. Defibrillation requires high energy. All right, because it's elective, cardioversion may take some time. In fact, that's why a lot of times, especially for atrial fibrillation, that has been there for 48 hours, before you cardiovert, you want to anticoagulate this patient. So you can have some delays, but no delay in defibrillation, okay? Anticoagulation is usually needed in cardioversion. It's not needed in defibrillation because it requires less energy, all right? It causes less damage to the myocardium, that's cardioversion. And this one is more for, all right, it causes more damage because it requires high energy. Cardioversion is used most of the arrhythmia except your VT and VF, but defibrillation is used most time in VF, especially because it causes pulseless rhythm and the patient becomes unresponsive. All right, so this is just another one to remind you, okay? Most of the time the patient is awake and you need to sedate the patient when you're cardioverting them, and they need to sign your consent form, all right? If it's a VFib, you defibrillate and you call it code, all right? It's a blue code, all right? You don't need time, you can't synchronize, and you defibrillate your patient. All right, so arrhythmias also occur in theater, all right? And, it may be due to surgery, it may be due to electrolyte derangement, or patient with pre-existing cardiac problems, all right? Incidence of perioperatic AF ranges from 20 to 40% in patients that are undergoing cardiac surgery, and up to 10% in patients that are undergoing non-cardiac surgery. So what are the risk factors for perioperative arrhythmias? Remember your charts, all right? Patients who have coronary artery disease, patients who are undergoing surgery under general anesthesia, or patients with advanced age, hypertension, patients with heart failure, or patients with electrolyte uremia, especially hypokalemia. Diabetic patients, all right, they have silent MI, you remember that, and this can predispose them to perioperative arrhythmias. Drugs like beta blockers, digoxin. Surgical stress itself can predispose patients to perioperative arrhythmias. So when you see abnormal readings on your ECG monitor, on your anesthetic machine, what do? You want to first of all determine, does this compromise the hemodynamics of my patient? So you want to assess your vital signs, ABC. You want to determine how serious it is. Then you want to look for the troubleshoot. Is the problem with oxygenation? Is the problem with ventilation? You look at your ATCO2 or the depth of anesthesia. And sometimes drug errors do occur in theater. You want to rule out drug errors or drug interventions or interactions. So if there's problem with procedure, for instance, when you are doing ocular procedure, your strabismus, all right? A lot of times when they're touching on those extraocular muscles, pulling on them, the patients may become bradycardic or have any form of arrhythmias. All you need to tell the surgeon, hey, guy, you are touching on those muscles. Please, can you just release pressure? And a lot of times, the arrhythmias, reverse. So you need to be on top of your game and communicate with your surgeon. Sometimes, like I said, rectal procedures, all right, proctoscopy, hemorrhoidectomy, these are things that can increase vagus stimulation, all right? In your obstetric patient, maybe the patient has thrown an air of fat embolism or even amniotic fluid embolism, all right? These are things you're going to look at, all right? Unexpected blood loss, is a patient, I remember a case like that, somebody had to give high dose of adrenaline to a patient who under spinal, and you could see the heart raise. It was a scary, I remember some years ago, it was a scary experience, giving high doses of adrenaline to a patient under spinal because the patient had hypotension following institution of subarachnoid block. The doctor just gave adrenaline, and the patient started screaming, my heart, my heart, my heart. So you want to be sure, was this patient given adrenaline? Or is there any mediastinal manipulation, all right? Maybe during thoracotomy or any form of procedure. Then once you're able to troubleshoot, you manage the kind of arrhythmia as per protocol. Okay, so in summary, management of perioperative arrhythmias, child, don't forget, I just like mnemonics so that you don't forget cardioversion for patients with persistent AF or other arrhythmias that are not responding to your medications. Always correct electrolyte imbalances, okay? Provide hemodynamic support for patients who are unstable. Antiarrhythmic medications, don't forget some Black people care. Sodium channel blocker, beta blocker, potassium channel blocker, and calcium channel blocker. Drug controls, all right, in terms of rate beta blockers and they just, and remember that they also can increase the risk of perioperative anemia. So in conclusion, arrhythmias are common findings in the ICU or in the OR, and they increase morbidity and mortality. Prompt diagnosis and management is crucial to optimize patients' outcome. Thank you. So we made it today. So any